Dr. Robert, for those who haven't come across you online, introduce yourself and tell our listeners what we're talking about today.
My name is Robert Pearl. I'm a physician. I wrote the book Mistreated, Why We Think We're Getting Good Healthcare, While We're Usually Wrong. My most recent book, Uncaring, How the Culture of Medicine Kills Doctors and Patients, was published 2 months ago. All profits from both books, actually, go to Doctors Without Borders, a really wonderful charity. And we're here to talk about medicine, the problems with the system, the problems with the culture, and wherever else our conversation may go today.
The subheading of your book, Kills Doctors and Patients. Might I jump to the conclusion that that's suicide?
A lot of conclusions sit in that subtitle. Relative to patients, what we're looking at is 100,000 people who die from medical error each year. We're looking at another 100,000 or more who die from failures in prevention, from complications of chronic disease that could have been avoided. There's a whole long list of ways that the culture of medicine contributes, along with the system of medicine, to harming patients. And for physicians, we're talking about a 44% burnout rate, and we're talking about 400 suicides a year, the highest profession that I'm aware of, and it's the stresses of taking care of patients in a system that is problematic and in a culture that is outdated.
When I think about something as drastic as suicide, it seems to me, and I ain't no psychologist, but it seems to me that it's maybe more than just like stress, that it's like a psychological problem, like not feeling worthy or feeling like they're letting someone down, or they're maybe depressed from a life they thought they might have and they're not having. And I know that maybe stress can bring out some of that, but would it be more than just stress? Is there something there?
A lot of it is the culture of medicine. Now think back to centuries, really until about the middle of the 20th century, physicians could do little to help patients. In fact, in the net aggregate, there was probably as much harm done as value gained. And in that situation, try to think about a culture that would evolve. There you are, you're a doctor, you have this newborn, 2-month-old child in your arms, and this child is dying, the parents are in tears. What you learn to do is to repress your emotion. You learn, how do you go out into the plague when you don't have any antibiotics or anything else to treat this problem? You've got to repress it. Now think about this. When you train in medicine, the expectation is you're going to work no more than 80 hours a week, but that doesn't include driving to the hospital, away from the hospital, preparing for the next day. This is a 100-hour, 120-hour. You have to deny your emotions. You have to never admit you're tired. Never admit that you're sick. Never admit that you need any help. And these, I think, are these values, these norms, these beliefs about the right way to practice, now put onto human beings with all the frailties that we all have, into places of stress. And I think the much higher rate of suicide is less about being a physician, but having to keep that emotion inside. And Mike, I'm really worried that in the post-COVID world, we're going to see massive amount of PTSD and suicide. I talked to a doctor, a friend of mine, a couple of weeks ago. He talked about losing 4 patients in one day. I talked to a resident. She had inherited 6 patients on the first day of her rotation. By the end of the month, all 6 were dead. How do you deal with those emotions? I mean, I can remember every death I had across a 20-year clinical career. But how do you do it when they all happen in one day or 1 week or at most 1 month? And you can't tell anyone. You can't admit you're exhausted. You got to get up the next morning. I think these are the pieces that contribute. In the book, I talk about the caduceus, this symbol, these 2 snakes wrapped and entwined around the staff that sits on the sleeves of a lot of doctors' jackets and around textbook covers. This is the system and the culture intertwined. They come together in ways that they can support each other, making doctors heroic, as we saw in COVID-19, but inflicting major harm. And you're raising a great point. It's this total emotional inability to deal with it. And in the book Uncaring, I write about a physician who takes his life and never tells a single person that he's hurting, that he's having psychological difficulties. And to the best of my knowledge, he never sought any help. That's the culture. It's a broken culture. It's left over from the past. It doesn't work in today's world, particularly not in the face of a pandemic.
All of that pressure is put on. They deaden their emotion. They replace it then with unhealthy defense mechanisms, let's say.
The two defense mechanisms that I highlight in the book are repression and denial. And these are the ones. If you find yourself powerless to help patients out, that's a difficult emotion. And so you start repressing that. If every day you have to go to the hospital, take care of patients with COVID-19.
It went back to the old ages where you have no idea how to solve it.
And you don't have the protective gear. You have to take a garbage bag and put it over yourself because there's no gowns, and maybe a salad lid to put on your face. There you are. You have to pass a tube into the lung, knowing every time that tube goes through the vocal cords, the patient is going to cough, spewing virus in your face. How do you do that? You've got to repress and you've got to deny. You have to repress and deny that you're tired, that you're having psychological problems. And so I think that people who otherwise could get help and could have done well find themselves isolated, alone, and suicide often, unfortunately, is the outcome.
I think about airline pilots. I don't even know if they're allowed still to say that they're on any psychological drugs. I'm not sure the rules on that, but I'm sure that it's not the cool thing to tell your doctor friends that you're going to go see a shrink for something.
Absolutely. This is the culture of medicine left over from the past and inappropriate for today. But the same denial and repression that allowed physicians to deal with their inability to help patients to get better are the same ones that lead them to overlook some of the things that they do. I mean, take an example in an area that I know you're very interested in, opioids. And I don't mean personally, I mean just professionally.
Yeah.
Okay. Why did the United States prescribe over 90% of the hydrocodone? Why do we have 90,000 deaths this year from drug overdoses? No question. The drug companies were evil. They told lies. These drugs can't be addictive. They can't depress your respiration so far that you die. There were a lot of ways that the drug companies, certainly for profits, were deceiving physicians. But who wrote the prescriptions in the end? And we continued to do so for a long time after, because it was more convenient sometimes to give a patient 100 pills and not have to worry about refilling a prescription than it would be to give them the 5 they probably needed, or maybe 10, and then have them call your office to get more medication. But we don't think about that part. We focus on the systemic issues. And culturally, we just deny our roles.
Robert, in that example, break that down. So you're saying that the doctors who had these stressors, it would have been additional stress to do the right thing in that area?
So in that case, it's not stress. It's the reality. You're very busy. And having a patient call your office.
The refills you were talking about.
It's a refill, and it's a narcotic, so as you know, that requires extra paperwork and triplicates and other things. So instead of giving the patient 10 pain medications and then saying, if you're still having pain on Friday, call my office and I'll get you another prescription, you give them enough for the worst case you've ever seen, not the most likely one or hopefully the best outcome, which is the pain will be gone by the end of the week.
Arguably, you could say, well, hey, let's make refills and let's add more office visits and more billing and all that stuff. But the refills would have been more of a pain in the ass than it would have been worth.
So I want to be very careful to make sure that listeners understand doctors are very hardworking and very dedicated. And I don't know any of them who would intentionally do any of these problematic pieces. But we're talking about culture and systems put together.
Gotcha.
Now, to the point that you're making, for 2 months after you do a surgical procedure, you can't bill for return visits. It's part of the fee of surgery.
Gotcha.
So there isn't any payment. If there was payment, would it be different? Maybe, maybe not. I can't say.
But right now it's part of the culture and we don't know.
But the point being that doctors are overworked. They don't have enough time. The computer systems are problematic. Everything is working against them. So they take every shortcut they can for both the good reasons and the more problematic. Both of them.
It's culture right now.
Everyone does the same. See, that's the thing about culture. When everyone around you is doing the same thing, you know, what do they say to the fish? How's the water? They say, what water? Because that's what's around them. Right. That's the situation that happens in a cultural. Every surgeon was doing the same thing. Every doctor was doing the same thing. But why didn't they stop to look at it? I'll give you another example. During COVID-19, 88% of people who died had 2 or more chronic diseases. The most common one was hypertension. Across the United States today, we control hypertension 55 to 60% of the time. When I was the CEO in Kaiser Permanente, we did it 90%. We had excellent doctors, but so did the community. We had excellent drugs, but so did the community. It's a cultural piece, and we don't notice it in medicine. What we see as clinicians is the systemic issues. Insurers don't pay enough. Patients don't listen to our advice. And we say, this is the best we can do. The fact that someone else is getting better outcomes doesn't penetrate in a way that forces us to do something differently to achieve a better outcome. That's the culture, because we're in a culture. What do we value as physicians? Intervention, not prevention. Treatment of the complications of hypertension, whether it's the stroke or the heart attack or the kidney failure, but not aggressively, continually able to achieve the outcomes that we could in a different system and a different culture.
So these were cases that we didn't even know about.
Oh, no, we knew about it. No, we knew about it. They had hypertension. It's just that if it took a year to get it under control, or 2 years, or if it sort of never really happened, that was just the way things were, and it wasn't our fault. It was the system. If the insurers paid more, if patients were more adherent to the medications we prescribed, if a lot of things were different, the computer systems were better, and every one of those points is true. But it also leaves out our contribution, and that's why I wrote the book, to try to make people aware of it. Give you another example. I mean, the examples, I use COVID only because that's what's happening right now. But, you know, I personally don't know any racist doctors. I'm sure they exist somewhere. I don't know anyone who intentionally provides different standards of care based upon the color of someone's skin. But what does the data say? Early in the COVID-19 pandemic, when 2 patients came to the ER with very, very similar symptoms, one a black patient, one a white patient, and there was a shortage of testing kits, we tested the white patient twice as often as the black patient, despite the fact that the data says that black patients were dying 3 times as often. People often ask me, do we have a racist culture? And at least in this example, I don't think it's a racist culture, Mike. I think what this is what's called implicit bias. What that means is 20,000 years ago, we're living in a cave. A human form appears over the edge, and we have a split second to say, this is someone from our tribe, let's welcome them. Or this is someone from the neighboring tribe coming to take our food away, and let's take the spear and kill them, all right? This is implicit bias. We see people like ourselves, whether they have the same skin color, speak the same language, worship the same God, as being part of our tribe, and we see people who are not as being in a different one. We can't control that. That's biological. But once we see the racism in practice, then, and do nothing about it, that is racism. Or we see the implicit bias in practice and do nothing, that is racism. What we know is that black women have 3 times the mortality in childbirth. What we know is that women having a mastectomy get offered reconstruction far less often than white patients with the same procedure. What we know is that when a black patient has an operation, doctors prescribe 40% less pain medication. These are the facts. And even though we don't think we're doing anything inappropriate, the data says that we are, but that same physician culture allows us to blame the system. The system is problematic. Black patients had more COVID deaths because they worked in jobs they couldn't stay home and work virtually. They took buses and subways to get to work. They lived in multi-generational homes. It's all true. And yet, once we see the data, you would think we would change our practices. But we didn't. You didn't see any great outrage, at least by most of the white physicians, because they all assumed, including myself and yourself, that the problem wasn't us. It had to be someone else. It's interesting, like, you go back to this whole issue. What is culture? Culture is the values and beliefs and norms. But, Ignaz Semmelweis, I love to tell the story about him. 1850, Vienna, Austria. He's appointed the head of the delivery service there. And he's appalled. 18% mortality rate. But he's also embarrassed because the adjacent facility, one run by nurse midwives, has 2/3 lower death rate. Now, at the time, what's the most common cause? It's called puerperal fever, a infection of the uterus that then spreads to the body. And how does the uterus get infected in the minds of the doctors of the 1850? Remember, Louis Pasteur has not come along yet. It's miasmas, smelly particles drifting up from the streets below. And then a colleague doing an autopsy on a woman with puerperal fever nicks his finger, gets a local infection, spreads to his body, and he dies with the same disease. Semmelweis says, oh my gosh, obviously there's something being carried from the autopsy area to the delivery area, maybe on the hands of the doctors, maybe on the leather aprons they wear to protect their well-pressed 3-piece suits. He makes them change aprons to go into the delivery area, dip their hands in chlorinated water. Mortality falls in less than a month from 18% to under 2%. He writes it up in the journal. He writes to the maternal delivery leaders across Europe, and guess what happens? Nothing. No change happens. All right, you say, okay, that's 1850. What are you talking about? Today, what's the leading cause of death in hospitals? Hospital-acquired infection. What's the most common organism? Clostridium difficile. It doesn't go through the air like coronavirus. It's carried by people. And 1 in 3 times, doctors today don't wash their hands. How do you explain it in Semmelweis's time? It's not because it's money. There was no cost in changing aprons, dipping their hands. It wasn't time. It was the culture that said doctors are healers. They couldn't possibly be responsible. Anyone who was blaming the doctor had to be crazy. And those leather aprons, the more blood, the more pus, the more experience, the higher your respect and self-esteem. And today, when we go from room to room 1/3 of the time not washing our hands, it's the same culture. We can't be carrying disease. It has to be someone else. But of course, it has to be someone. And it could just as well be you or me if we fail to wash our hands. It still takes no money. It still takes no time. It's purely cultural. It's inexplicable. Or look historically, when a physician named Hermann Boerhaave meets Daniel Fahrenheit, and he gets to see this thermometer. He says, oh my gosh, we can differentiate health from disease objectively. And what do doctors respond? Forget it. Our hands are able to discern this better than any metal and mercury. It's not true, but the culture elevates the things that we are most proud about, and it makes us ignore opportunities. And of course, as you well know, the Rand Institute has shown it takes 17 years today for a great idea to become common practice. That culture persists, and telemedicine is even a better example, where we had it all along and we didn't use it until COVID comes along, and all of a sudden within 1 week, all the doctors start using it. You see, when you start looking for culture, you see it almost everywhere, intertwined with the systemic issues that doctors and patients and nurses and pharmacists all face.
My dad, let's say he'd be talking about the minister, the priest or something like that, and then someone would chime in. They're like, well, yeah, but they've got such a tough job. They're in charge of all this and all this. I remember my dad, I can hear him now. He's like, yeah, I know, but they're also in that position, and we have to look at that position and find out where the problems are. It's like you don't get a pass from that. Doctors hate technology. Tell me about that.
This is another example of where the system and the culture come together. Doctors hate technology for 2 reasons. They really hate technology that slows them down and makes their job tougher. All right, the electronic health record is a good example of that. It was never designed for patient care. It literally comes between them and their patient. But they also hate technology that lowers the esteem of the profession. They love things like robots and proton beam accelerators, because that makes doctors special, Star Wars kinds of opportunities. Mm-hmm. But things like telemedicine, they're never going to see that as good as a doctor's office visit, because in our minds as physicians, the office is the pinnacle of care delivery. If you want to come in and see me, what do we call that first room? It's the waiting room. Your job is to wait until it's convenient for me.
There's something wrong with that.
That's a cultural piece. This is nothing negative about doctors. They are hardworking, they are overworked, but this is the culture. The truth is that telemedicine can provide care quicker, immediately, more conveniently, less expensively. It doesn't replace everything, but let's figure out the things that it does better. That's not the culture and the mindset of physicians, the things that elevate us. What do doctors hate? Doctors hate algorithmic, artificial intelligence type of information coming at them, telling them how to practice. They don't want, that's cookie cutter medicine. That lowers everyone to become average. The data says exactly the opposite. It actually elevates quality, improves outcomes. It's not that there's never an exception, but an exception should be rare. And that's not the way physicians see these tools. Now remember, it's going to flatten the hierarchy of medicine. And a guy named Sir Michael Marmot from England has looked at this phenomenon. And if your status drops, because now what you do can be done by others, the symptoms are lack of fulfillment, dissatisfaction, and fatigue. Exactly the symptoms of burnout in the profession. And I think a lot of what's happened in the 21st century is physicians have lost that esteem, not because they've done anything wrong, but patients, rather than accepting the paternalism of the 20th century, now come having looked at the internet. We as doctors say, it's terrible information, don't look at it. That's not how the patient sees it. The patient says, if I can get these services in banking and travel and retail, if I can get that convenience, why shouldn't I get it in medicine? And doctors hate the idea of the patient as the consumer, but that's what patients expect now. And as a consumer, that vertical hierarchy has just gotten very much flattened.
So the technology that's cool, like these robot arms, it's like, if I'm a doctor, I like that because no one else can come into the surgery room and get to use these clippers and this kind of thing. But we don't like the AI in the waiting room or the stuff that just helps the consumer squish the profession because anybody can do that. So the cool technology is okay, but not the stuff that is taking away some of our mystique.
Absolutely. And the cool stuff is really good if it also generates significant income, which the robot does as well. The system and the culture coming together, not consciously in the minds of doctors, but that is, if you step back and look at it, what you see. I'll give you another really, to me, fascinating example. It's December of 2019. The U.S. government puts out an estimate of what's going to happen to healthcare costs over the next decade. And it says after detailed analysis, they're going to go up 5 to 6% a year for the next 10 years. And that's a compound interest rate. You do the math, healthcare is going to cost by 2030 $2.5 trillion more. That's a big number. Think about what you could do with $2.5 trillion for prevention, for education, for the homeless, for people who don't have the right food to eat. You can go down the list of opportunities for children and early development. All the things we could do. I saw this report. I waited to see which of the professional societies would say, this is ridiculous, the idea that we should assume that medicine will just keep going up at 5 to 6% a year. Every other industry has used technology to lower costs. Why are we the only industry that it's raised cost?
Yeah.
And no one stepped forward. In the culture, this is what was expected. You do the math, you do the calculation, it's 5 to 6% more. That's the best that we can do. The culture of medicine, the system of medicine come together, and the people who get harmed are the patients and, as I point out in the title, the doctors who deliver that care.
Amazon. It used to take me like 3 weeks to buy a damn Dell computer. You know, I'd have to think of all the stuff that I wanted to get and not get, and I'd be nervous and worried. And now you can go on Amazon or whatever, and not all the listeners care for Amazon because of the disintegration of some of the brick and mortar. But you go on Amazon, you can buy a computer now in 3 minutes just by taking the Amazon choice or the next one down or this or that. But there's still an art in saying, all right, that's fine, but what is this going to be for Mike and for my family? And what if my kids want to use this? And what about the screen? Am I going to want to use it on my kitchen table? And how's the sunlight coming in? Do I need a certain angle or a certain, there's a lot of personality that goes on in addition to that base stuff. And so I just think there's a beauty that computers can bring, and the physicians are still there maybe solving those big problems that they can't solve for all the mush in the middle that they're still spending 80% of their week on, something like that.
You're raising a really important point. And I would say that I could buy a computer for your family, and a year from now, everyone would be happy with it. I mean, it might not be the one they would pick exactly for their own need. Some people want a Mac, some people want a PC, some people want maybe a little bit bigger screen, smaller screen. But 90%, it will be just fine to accomplish all of that.
Yeah.
And we should look at the 10%. If we're going to buy a computer, it's a lot of money to spend. But we shouldn't overlook the 90%. And at some particular point, we're going to say, this is basically the equivalent, and why not purchase the less expensive one? Or we might buy the more expensive one, knowing that it's a somewhat of an extravagance to do so, because it's not going to really make any difference, but we like it more, so we're going to do it. And I think we overvalue as people that individualization. 90% of people with the same disease and the same problem get the same treatment. The 10% are very difficult. They're very complex. They have multiple diseases, but we tend to ignore the part that's relatively straightforward and say, okay, how can we leverage that in a way to improve care for patients, to get it to them sooner, more conveniently, less expensively? We don't do those things because, again, it goes against the physician culture. We tell ourselves we shouldn't even think about money as doctors. We should just prescribe what we think is best, ignoring how many people have economic challenges as a consequence. It's the leading cause of bankruptcy for Americans. The number of people who go to collection. But again, in the culture of medicine, we don't see that. We call that an insurance problem. No, for our patients, it's a real problem. And so I'm hoping that we can overcome some of this repression and denial about the healthcare system. Not that it's not broken. We need to work to change it, but also the ways that we either could help or the ways that we sometimes actually contribute.
So, Robert, you brought this up yourself in a LinkedIn post you recently had talking about your book review on Amazon. More than not, a lot of 5-star, whatever that is, but also some that were way down at the bottom. Probably like a lot of times, the negative opinions were not so much an attack on your ideas, but kind of a personal attack, which is easier to do when you can't fight the idea. But your approach on it was to say, hey, these last few years, we've all been kind of just thrown into these same thought patterns and you kind of groupthink and so on. And you were happy to see the conversation starting, whatever the opinion was, you were happy to see that conversation starting.
So in total at this point, the book has a 4.5-star rating, which actually by the experts on social media, I'm not one of them, but I've read them, 4.5 is perfect. Because 5 is unbelievable.
Yes.
And then when you start dropping down below that, it becomes lower. But it's actually interesting to me, as you pointed out, that probably, 80% of them are 5 stars and maybe 20% are 1 star, or whatever the numbers turn out to be.
Yeah.
And it just doesn't happen except when there are other factors at play. And that was why I was comfortable. In fact, I saw it as an inevitability. Because I think this change process will involve loss and grief for physicians.
Yeah.
And I write about it in the book, The 5 Stages of Grief by Kubler-Ross, a great book for anyone who has not looked at it, or a great set of research. The first thing is denial. And I think that really defines the medical profession for the past 20 years. We didn't see yesterday, the Commonwealth Fund came out with rankings of the 11 industrialized nations in the U.S. in the world. And where was the U.S.? Last, number 11. Last in life expectancy, last in childhood mortality, the highest maternal mortality.
That is crazy.
We tell ourselves it's the best in the world. We're in denial. It's not the best in the world. So denial is the first stage. And the second is anger. And that's how I saw the 1-star ratings. People were angry. I'd pulled back the curtain and let people see inside medicine. It's the blue wall of silence for the police. Every profession has this way of protecting our own, and I had let people see it. And people were fearful that somehow, by letting people in to see the issues, we were going to make it impossible to get the systemic changes that we needed, and I saw it exactly the opposite. Because we've been yelling about burnout for a decade. And nothing has changed. It's like being in a foreign country and thinking if you just yell louder and louder and louder, they'll understand you. No, we're not understanding that this is not going to happen until we lead the way. So I think it's an important second step. The third step is bargaining. And it's interesting to me that 70% of doctors are no longer in private practice. 70%. 50% of them get paid either by a hospital, by an insurance company, by private equity, by a medical group. This is the bargaining, but I don't think it's going to make the change because I think the change is problematic inside medicine itself. And the fourth one that I'm really worried about is depression. And then finally, there's acceptance. It's not acceptance saying this is a good thing. It's just saying this is what it is and how can we lead the way out of it? So I believe that we have to move from a fee-for-service system to a capitated system where doctors and hospitals are paid a set amount of dollars to provide care to a set group of patients with quality and service expectations. That in doing that, it not only moves the system of medicine, it moves the culture of medicine. Because when you're paid a set fee to take care of a population of patients, you value prevention, avoidance of complications from chronic disease, patient safety. You elevate primary care. We know from the data that adding 10 primary care physicians increases longevity and health 2.5 times more than adding 10 specialists. And yet in the United States today, we elevate the specialists far above primary care. And it leads to a need to create an integrated care delivery system with collaboration and cooperation, opportunities to take out cost, not by working harder and longer,
right,
but taking out inefficiencies. How often we prescribe a brand name drug when a generic has exactly the same by law chemical structure, opportunities to be able to stop doing the 30% of things the Mayo Clinic has shown add no value, the opportunity to be able to use technology like telemedicine for care that's quicker, higher quality, and lower cost, and to embrace a leadership structure, something that today doesn't really exist in healthcare today, someone who can organize that entire process to make sure we have the right facilities, the right physicians, the right teams of others, the nurses, the pharmacists, the respiratory therapists, all of the pieces. And when they come together, all those 4 parts, I believe we have the opportunity to raise quality 20%, service 20%, and lower cost 20%. And that's a pretty powerful package compared to where we are today. And it would take America from being last to becoming potentially at the top of the list.
It's embarrassing to rank that low. Back in December, so half a year ago, we were that close, a half inch in my fingers, close to closing up shop. And part of it was because of the mixed up reimbursement on brand name drugs. Because long story short, we had $500 inhalers on our shelf and the insurance wouldn't pay for the exact same generic that was $100. Somewhere there was $400 that needed to stay in that system because of the way things are set up. And then here we are on the bottom of the list. And it's like, that sucks.
So it would be very presumptuous of me to actually delve deeply into the pharmaceutical world because you and your listeners are so expert about it. But talk about a broken culture where the intermediaries are taking money. No one knows who they are. They're only passing it on to consumers if consumers are going to come and buy the more expensive drug. I mean, I could go down a list. You could probably spend 3 days educating people about how broken that system is and that culture is, because the culture accepts that as the way it should be. In fact, it brags it's better when there's no data, from my perspective, that it's actually true.
My hope with medical is that we're still in the buying a Dell computer stage. I mean, I'd hope that it gets so simplified, and I'm not even exaggerating here. You hope it's so simplified where you're almost on your iPhone. You're saying, yes, I need a new heart or this or that. You know, I know that's simplified, but they've done it with a Dell computer. I mean, they ought to be able to do it with someone's heart. What's the difference?
If you wanted in the 20th century, 20 years ago, to carry all of medicine with you, you want to have all the information, you'd need a 50-pound backpack. Right? So what did we value in the 20th century as physicians? It's the ability to memorize arcane facts, right? Because that was the piece. You want to get into medical school, you take a test called the MCAT. It's a series of arcane facts. And then when you want to apply for residency, it did what's called step 1. It's even a more set of bigger arcane facts. And if you could memorize, every infectious agent and the drug that would be recommended and the exact dose that was there, you did really well. Now what do we have in your pocket? A smartphone. You don't have to memorize any of this. You want to know what the drug is, what the dose is? You take a phone out of your pocket and you click on it. And yet, what do we still use for admission to medical school? This arcane approach. As far as I'm concerned, every medical student should be required to bring the cell phone, the iPhone, to the exam. Have the test starting with what's available there, because that's what you're going to have in the exam room. But that's not in the culture of medicine. We hold on to these values left over. Going back to the conversation before, it's our intuition. It's our anecdotal experience. Why is that? Because in the 20th century, that's all we had. But today we have so much more, and we don't value it. I'm not saying we never use it. We just don't value it, to elevate it, to maximize it. And the consequence is medicine is way too expensive, and the quality and the service and the convenience are inadequate compared to what is possible. In fact, this whole process begins, I don't know if they have it in the pharmacy world as well, but it's called the white coat ceremony. You show up for medical school on the first day. You come with your parents. You're called one by one to walk onto the stage, and there a faculty member takes the white coat and drapes it over your shoulders, with one exception. If your parent, one or the other or both, are physicians, they can put the white coat on you. Now, I want you to think about that. If your parents are physicians, are they less proud of you than the family of two immigrant parents who both work two jobs so their kid get to medical school, or the one whose parents were laborers in the farms, working 12 and 14 hours? Why should these parents who are doctors get this privilege when no one else does? And the answer is, this ceremony has nothing to do with the pride of the parents. These are the parents saying to the academic faculty, you can instill your culture in my child. I give you that privilege today, because the ritual is the passing on of the coat. Just like in the Middle Ages, in the medieval times, the king would take his daughter and marry her off to a prince in another land with the permission that she would now adopt the prince's culture rather than her own. Even though we never talk about culture, and I'm not aware of any other books in medicine that write about it besides Uncaring, it's clearly built into our institutions, our experiences, and what we spoke about before, this absurdity of spending so much time and value on memorizing arcane facts. It should come as no surprise that burnout in medicine starts in the first year of medical school. Ask doctors, why are you burned out? They'll tell you it's three things. We're not paid enough, so we have to see too many patients. We have to go through authorization processes because of prior authorization, bureaucratic tasks, and because we have to use this computer system that comes between us and the patient. But the first year medical students has none of those things. And yet they equally get burned out.
That ceremony, you're saying that the parents who are up there as the physicians, that's like symbolic of saying we want our culture transferred to the students and carry on.
It's that they can be trusted to pass on the right culture to the students because they're doctors. They've already been indoctrinated in it. These other parents, they can't be trusted.
Gotcha.
Because who knows what they're going to teach. Maybe they're going to teach, that prevention's important or whatever it's going to be that violates all of these pieces that we're about to instill in medical school and in residency. But the parents who are doctors, they already know repress your emotions, deny that you're hurting, don't ever admit you need psychological help, all the things we talked about earlier. They know those things. When their child calls them up and says, I'm having problems, they say, buck up. They don't say, go see a psychiatrist or a psychologist, whoever's there. And when the problems happen because the psychology is not addressed, that's tragic.
I was speaking to a physician on one of my earlier shows, and they were saying that you could tell what year a physician graduated by the medical choices they were making or the drugs they were using. Mm-hmm. So in other words, if you took a doctor and said, how did they treat such and such? Well, they used drug X. Oh, I bet they graduated in, 1980. The point is, I can't imagine someone who comes from a world of, now I can do my 4-star Amazon computer purchase. I can't imagine these doctors having to keep up. I mean, you think about the exponential knowledge that's happening in medicine, and to think that someone's mind is trying to bring in the new information, combine it with the past and all that kind of stuff. It's like, yes, talk about stress and also talk about how could we not use technology for this now?
I'll go back to what I said earlier. Doctors work so hard, and I'll use the phrase too hard. And you're making a key point. They don't have time to stay up with every change that's happening, particularly in primary care, where you have to know the heart, the lung, the brain, the intestines, and so on down the line. So they use what they know works. But the opportunity exists. You just made a really good point. And we have technology, don't get me wrong, and we have tools to be able to do it, but to build that into the learning process of how you care for a patient so that the technology and your skill go together rather than it being available if you need it to look it up. No, you start in a different kind of way. Now, this is the medicine that just needs to be, but it's not today. And that's why I keep pushing for these, I'll call it the systems of care. Some of the pharmaceutical problems start to disappear when you have a fully integrated care delivery system where the pharmacy and the care delivery and the insurance process all come together to say, how do we provide the drug that is going to be the right one for the patient and make sure that it becomes affordable to the individual, because the best drug that isn't taken isn't going to be very effective.
I'm curious, and this is getting into the nitty gritty, but it's kind of fun as an outsider to talk about this. But you had mentioned in an earlier interview how some of the urologists, they're no longer recommending certain tests being done, and those tests kind of gave the urologist kind of a higher feeling of status. And as soon as that was gone, they felt like they lowered their status, and that was a psychological downfall for them. And that gave them more stress because they were in a lower stratosphere of respect compared to other doctors and so on. Are there other psychological things going on like that? Are there anxiety and fears and embarrassment and stature? What are some of those things that doctors come across?
The issue you're talking about is burnout. If you ask physicians about it, they'll give you 3 reasons. Not enough money, which means too many patients, too much bureaucratic tasks around authorization and the computer system. Those consistently are the top 3, and they're all problems. But in the book, I dig deeper and I say, okay, let's compare some specialties. So you're referring to urology. Urology, prior to the pandemic, was the most burned out specialty of all. Urologists make almost $500,000 a year. So if it's money, that can't be it. They don't see any more patients than other surgical specialties. They have the same authorization process, let's say, as orthopedists, who have 25 lower points in burnout rates. They have the same computer systems as ophthalmologists, who have 20 points lower. They make twice as much as pediatricians, who have 10-point lower burnout. So how do you explain urology being the most burned out specialty? And this is the point you were making, that 2010, they were actually relatively low. And then the National Preventive Services Task Force said, we don't need to do PSA on all men over the age of 50. So the number of cases of people with prostate cancer started to decline. And then we said, watchful waiting is often pretty good. And by the way, the surgery leaves you impotent and incontinent. So maybe that's not such a good thing to have done. Right. So even fewer got done. And then centers of excellence came along. So many urologists stopped doing this operation that, as you said, was the Star Wars. It's what gave the esteem. It was the shiny, bright object. And now it goes away. And when that happens, you're absolutely right. It's the esteem, the respect that disappears. And we don't think about it that way. But Sir Michael Marmot has shown that is as important as money. In terms of your sense of fulfillment, your satisfaction, your energy every day that's there. So urology is one example specific to the machine, but primary care is another example. What's the problem in primary care? The problem in primary care is we've made so much progress that so many of the things that used to require intuition and experience, we now have algorithmic approaches and checklists and other things that can be followed. And what's the problem when it can be followed? Almost anyone can do it. And now you're seeing nurse practitioners and you're seeing PAs taking over a lot of the things. Urgent care centers starting to do a lot of the pieces, and the role of the primary care physician, who used to be the most sought after specialists. If you were really smart, you became a primary care and internal medicine physician. And if you were not quite as smart, maybe you became an orthopedic surgeon. That's all flipped around now, where the people, at least who score the highest on the examinations, are the ones who want to become the orthopedic surgeons or the cardiac surgeons, rather than the primary care. We highly value deep knowledge in a very narrow piece. But who's going to coordinate everything? This is a role that primary care can do so well, but you can't expect primary care to have the full, deepest knowledge about every organ and every disease that exists. So they become more, I'll say, generalist. And what they should be, from my viewpoint, are quarterbacks of the team, coordinating everything. It should have a high esteem value, the same way a quarterback does on a football team, but that's not where it is in the hierarchy of medicine, and therefore we're seeing primary care being one of the most burned out specialties, in addition to the bureaucratic tasks, in addition to the computers, and in addition to the number of patients that need to get seen every day.
It seems to me that the primary care guy still is kind of the quarterback, because don't a lot of the referrals and stuff have to go through the primary care, or is that old thinking on my part?
They don't have to go through there. They sometimes do, but once the referral happens, they're often out of the picture.
I see.
And I use as an example, my mom was in the hospital. She had a chronic leukemia, kind of acute flare-up. Then she ended up having a pneumonia and a stroke. She had a neurologist, a pulmonologist, a hematologist, 5 people.
Yeah.
They all came by every day. They wrote notes. There was no connection. There was no one who was quarterbacking that team. The primary care physician never even came to the hospital anymore.
They made the referral, but it's kind of like calling in the play, but they're not the quarterback of the play still. They're out of there.
Exactly. They may be the guy in the booth calling in the play, but once it goes on the field, there's now become someone else. That's a role or maybe there's no quarterback. Maybe that's a better analogy. And what we need is to have someone there. And I believe that that's missing. And as a consequence, patients fall through the cracks. People can't figure out exactly where do I go, who organizes it. And this is a major need today. But patient convenience, patient time in the culture of medicine isn't that valued. And so when you step back from it, we expect the patient to do all of that coordination and navigation, and we undervalue the individual who we've already trained to be an expert in so many different areas. It's just where medicine is today.
So, Robert, pharmacists, maybe they can help. Is there anything that the general public can do, or is this all going to be internal/political? slash big business making these changes? Where does this change happen?
Well, I think there's a lot of things that pharmacists could do. So let's start there because of the science. So the classic example is someone who has a need to have heparin, a drug to thin the blood. And I'm sure some of the people listening in are not pharmacists. The pharmacists are going to know everything I'm saying. But I'll explain a little bit more detail for whoever else is listening in.
Explain it to me because I probably don't have it either.
Okay. So not heparin. So warfarin. So a blood thinner, your dose is based upon your blood clotting results. And the data says that pharmacists actually do a better job than physicians. It's very formulaic. Pharmacists are experts on drugs and the complications. They understand the dosage extremely well. They're going to make sure that they get it right. They're not going to cut corners. And the results indicate that it's far better. Now, when you get to 3 and 4 and 5 diseases all interacting, that's a very complex patient. But when you're looking at patients, particularly in the early stages, let's say for diabetes, you can do the same thing with wearables and data and information. And rather than adjusting the medication every 3 months, you can adjust it more frequently. Or hypertension. You can actually take a lot of the tasks that are given to primary care and actually have pharmacists doing it if they have the full data information. And that's the second problem, because you need to have complete information. If not, you can make a major mistake. But I think there is a significant role. And so far in the culture of medicine, doctors have resisted this type of, I'll call it, teamwork, because it is threatening from a cultural perspective to the esteem and the respect, but it shouldn't be. It just requires a new definition of what's most valuable. And when you start to say preventing disease, avoiding having to amputate a limb, going blind from diabetes, kidney failure, hypertension, the most common cause of strokes, you go down the list of diseases and you start to say, why wouldn't it be a lot more valuable to prevent them in the first place than to try to treat them? Now, all of a sudden, you open your arms wide and you say to the pharmacist, come on in. This is a team effort, and together we can do far better than either of us alone. That mentality, that psychology does exist in a few fully integrated medical groups, but not in the majority of American medicine. It's just not valued high enough. And why is it not valued? Because it starts to lower the esteem accorded to physicians. And again, I want to keep going back to the point. I say this not out of criticism. This is how every culture works. It's just that when you're talking about the culture of medicine, it's not just about the providers of the care. It's also about the patients who are the recipients of that same medical treatment.
You mentioned it about capitation and so on. I guess money talks. Maybe capitation helps to open people up to say, hey, if I can get some help with this, I'll take a little lower esteem. If I'm kind of joking, because we talked about esteem is as important as money sometimes. But if I'm going to lose maybe both, I might as well at least have my pocketbook still doing okay.
You can think about a general contractor and all the subcontractors. And the subcontractors have a lot more knowledge than the general contractor about each of those areas, doesn't feel as though he or she is losing respect because they've asked the electricians to take care of the wiring and the plumbing to take care of the water.
Right.
But in medicine, we still have some of that where the general contractor, who to me should be the primary care physician, has lost both that role and the respect that would exist elsewhere.
I wish the respect, if we said, okay, guys, the respect is going to come from really healing people and really making the U.S. go from, 14th on the list up to number 1. Let's get all the other stuff. Let's just make that as the Amazon choice. Let the pharmacists help with all that kind of stuff. Let's get our respect from being way up here on the list and saving people in that and not from some culture respect.
So, Mike, it's interesting. I did a lot of trips to other countries. I fixed kids with cleft lip and cleft palate. and I've operated in South America and Central America, Samoa, a bunch of places around the world. And when I was the CEO in Kaiser Permanente, I sent doctors, by which I mean sent, they volunteered, and I facilitated their being able to provide the care. It's remarkable to me that you'd go to a country for 12 or 14 days, you wouldn't get paid, it's volunteer work. You're working 14, 16 hours a day. There's no air conditioning. It's incredibly hot. You eat rice and beans all day. You have intestinal problems. Every doctor came back so fulfilled, so full of energy.
Right.
I think of a physician who volunteered to go to Liberia to take care of people with Ebola. He had to have an IV in his arm because the suit that he had to wear was so hot. It was 120 degrees. He would have passed out from dehydration. I've never seen a human being so happy because he was making a difference. And we've lost that, Mike. We've lost that in medicine. It's been done to us. Every physician listening in, yes, the insurance companies done it. The hospital administrators have done it. The drug companies have done it. But we've also allowed it to happen or done it to ourselves, however you want to view it. I don't know if the ratio is, 60-40 or 40-60, but I think the time has really come for us to acknowledge the things that we contribute to and the ways that our culture stops us from making changes. And in doing that, we can, as you say, make American medicine become the best in the world once again.
Robert, a high schooler comes to you right now and says, I'm going to be a physician. What are you telling them?
You're choosing the greatest career that you possibly can. The privilege to save a human life, to be brought into the intimacy of an individual's existence and problems and wishes and hopes is a remarkable, remarkable gift. Please do it, but don't forget how you feel today, a decade from now. Never forget why you chose to become a physician, the mission-driven spirit, the purpose that led you to do that. And every night for the rest of your life, before you go to sleep while you're brushing your teeth, look in the mirror and ask yourself one question. Did I treat every patient today the way I'd want for me and my loved ones? And if the answer is yes, have a good night's sleep. And if not, make sure that tomorrow you do better than you did today.
Wise words. Robert, what a pleasure talking to you. That was fun.
Thanks, Mike. Yeah, that was fun. We went all over the place, but I know that a lot of your listeners are pharmacists, and I wanted to make sure I brought a little bit in, but I didn't want anyone to think that I thought I knew 5% of what they knew. I can just scratch the surface, and hopefully I gave them a view inside the medical profession, and they can take the pharmacy world and extrapolate into their own experience.
That's where we share something in common, because I know about 5% of what my listeners know too. So you and I are in good company.
There we go. And if any of them want more information, they go to my website, which is robertpearlmd.com. And if they want to obtain the books, they say All Profits Go to Doctors Without Borders, but they can get information on the 9 different sellers of the book. It doesn't actually go through me. And if they do so, I really would like to hear their thoughts. This is a work in progress. As I've said several times, this is our opportunity to once again make American medicine the best. I can't do it, you can't do it, but together we all can be successful. So thank you so much for hosting the show.
All right, Robert, take care. Great talking to you.